fistula with the initial ocular symptom. So this is often happen in the patient with the congenital, or sometimes the patient have a tumor of the curry or upper eye. And in our hospital, we not treat this patient, but when the patient happen with the cavernous fistula, we often send to general hospital. For example, at my Olympia's treatment with the patient. Thank you for your talking.
Good afternoon, everyone. My name is Sinh. I'm staff from the department, and today I'm so pleased to present a topic about bilateral cavernous sinus anterior-venous fistula with initial ocular symptom. There are 5 parts I will present in this presentation. The first one is clinical cases, and the first case is about a female patient who was 66 years old, and she had a red eye in both eyes for over 20 days. She had a history of hypertension, but no history of trauma, diabetes, hyperlipidemia, hepatitis, tuberculosis, and drug allergy. She had no growth, and the best corrected visual acuity in the right eye and in the left eye were the same, which were 20/40. And the IOP in the right eye was 19 millimeter of mercury, and the left eye 30 millimeter of mercury with the use of Gilchat and Condigan. The picture shows the congestion and total epithelial vessel, and here you can see, there was also slight bronchosis in both eyes. This is the magnetic resonance angiography image, and you can see the blue arrow show the fistulas, and the last picture shows that the cavernous sinus filled in the arterial phase. This is the result of MRI I have mentioned before. However, we also consulted some experienced radiologists, and they said that actually it was a case of anterior venous fistula instead of carotid cavernous fistula as in the result. Unfortunately, we don't know the result after the treatment of this patient because she didn't come back. The second case I want to present is a female patient who was 42 years old, and she had conjunctival congestion for half a year in right eye, and she had diagnosed with conjunctivitis, and the thyroid hormone test was normal. So she was prescribed with levofloxacin eye drops, but the size and the symptoms were not improved. She had no history of hypertension, diabetes, hyperlipidemia, hepatitis, tuberculosis, and drug allergy. And the best corrected visual acuity in the right eye is 0.4, and in the left eye is 0.8. The IOP in the right eye was 14 millimeter of mercury, and in the left eye was 30 millimeter of mercury. Her degree of eyeball protrusion in the right eye is 80 millimeter, and in the left eye was 40 millimeter, and she also had no blood. The picture shows the eye congestion in both eyes of this patient, and the total epithelial vessels as well. This picture shows the change in the fundus of this patient, and you can see the expand of the vein, retinal vein, in comparison with the artery. This is the magnetic resonance image of this patient, and the white arrow show us the enlarged superior ophthalmic vein of the right eye. And you can also see in this picture. This picture also shows us that the enlargement of ocular muscles. This is the DSA image of this patient, and the image shows that the right middle cerebral artery was stenosis, and the smaller distal blood vessel were replaced by messy small myoid-like arteries. And you can see the superior ophthalmic vein also enlarged. This is the picture of the SA after the intervention, and you can see the injected blue black around was completely dispersed in the sinus, and the antevenous fistula was completely occluded. And the patient exothermos and congestion symptoms were improved at the first day intervention, and after 3 weeks, the visual acuity of the right eye improved to 0.5. The next part I want to present is some information that is busy. Cavernous sinus anterovenous fistula can be divided into 2 main types. The first one is direct carotid cavernous sinus fistula, CCF, or indirect carotid cavernous fistula, neuroanterior venous fistula, DF. CCF is an abnormal connection between the internal carotid artery and cavernous sinus, and it often occurs after a trauma or an intragenic intervention, and its characteristic is a high flow fistula. On the other hand, DF is an abnormal connection between the meningeal branches of the internal or external carotid artery or both to cavernous sinus, and it is often a result of degeneration, especially with patients with hypertension, vascular disease, atherosclerosis, and its characteristic is a low flow fistula. So the signs, the symptoms are quite obvious. This is the detailed classification of anterior venous fistula. There are 4 types, and you can see the type A is the direct connection between the ICA and the cavernous sinus. The type B, C, and D are the connections between the meningeal branches of ICA or ECA or both to cavernous sinus. There are some signs that patient can complain with us. The first one is headache, diplopia, blurring, and brood. Diplopia in this disease because of the nerve palsy and the congestion within the orbit. The blurring and the brood are often ipsilateral with the fistula, and the brood often occur in CCF and less in DF. The brood can increase when patients do activities and decrease when they hold their breath. Some symptoms that we can discover when we do eye examination. The first one is discrete visual acuity. The second one, proptosis. The third one is the brood, and finally are some ocular symptoms. Visual acuity often decreases because of the ocular ischemia, elevated IOP, choroidal effusion, vertigo, or papilledema. Proptosis is one of the most important symptoms. It is the result of chronic increased ocular vein pressure, and it always appears in CCF but rarely appears in DF. Its characteristic is ipsilateral with the fistula, and it is non-axial. The pulsatile proptosis caused by arterialization of the ocular vein occur in 5 to 20% of patients with DF. Some ocular symptoms I want to mention are chronic red eye with total epipupil vessels, eyelid and conjunctival edema, elevated IOP, changes of fundus and motility abnormalities. This is the symptom of chronic red eye with total epipupil vessels. Elevated IOP can be the result of venous outflow obstruction and blood in the slave canal, and it often appears in 20% of patients with DF, and it is quite insidious. This is a patient with blood in the slave canal. There are some further changes in this disease. The first one is papilledema. The second one is total and enlarged vein, and finally, we can see the retinal hemorrhage. Nerve palsy is the cause of mobility abnormalities in this disease, and this picture shows a case of sixth nerve palsy, which is the most common in this disease. The second one is a case of third nerve palsy, and the last one is the fourth nerve palsy. This paragraph shows the position of cranial nerve in cavernous sinus, and we can also see the relationship between the ICA and the cranial nerves. You can see behind the ICA is sixth nerve, and you can also see the position of third nerve and fourth nerve. Because it's quite difficult to diagnose the anterior venous fistula through clinical examination, so we have to perform some paraclinical. I'm sorry.
Có một phòng luyện này là phòng luyện mấy buổi làm tội của tôi mà phải chạm sữa thôi. Bây giờ nó hỏng
I will continue my presentation. I want to mention four five clinical tests. The first one is ultrasound, the second one is CT scanner, MRI, and DSA. DSA is one of the most important, and it is the gold standard to treat and diagnose this disease. The ultrasound image of a patient with anterior venous fistula, and you can see the blue arrow show us the dilated superior ophthalmic vein in retrobubal space, and the second picture shows us the reversal of blood flow on Doppler. It is the result of the anteriorization of the vein. The next picture is CT scan image, and you can see on this picture there is a dilated sinus cavernous and the superior and dilated superior ophthalmic vein. You can also see that the intracranial arteries and the superior ophthalmic vein fill at the same time during the anterior phase. Besides, you can also assess the proptosis and ocular muscle changes. MRI is also helpful to diagnose this disease. On the picture A, you can see it's revealed expansion of the left cavernous sinus and dilation of left superior ophthalmic vein, the white arrow. And the picture B, it reveals slight thickening of the left lateral rectus muscle and enlarged left cavernous sinus. Magnetic resonance angiography is quite helpful to diagnose this disease, but the sensitive value is not high. And the last but not least is digital subtraction angiography, or DSA. DSA is for fluoroscopy technique used to visualize blood vessels, and radial part structures such as bones are eliminated, so we will have an accurate depiction of the blood vessel. And the subtraction images can be viewed in real time. And as I told before, it is the gold standard of arteriovenous diagnosis and treatment. This is the DSA of a patient with uroarterial venous fistula. How about the treatment? Treatment of this disease depends on the flow. If patient have a high flow, we have to block the fistula with coils or glue through arteries. But if patient have low flow fistula, we can observe, because some of them can close without any intervention. But if it cannot, you have to block the fistula through the vein. So actually the treatment of this patient will be performed by radiologists, but sometimes a transvenous approach by transcutaneous canalization of superior ophthalmic vein is employed for embolization. So it needs the help of an ophthalmologist. A summary about this presentation. So you can see PF is a rare condition and is the result of the degeneration and is a low flow fistula. It often occurs in female patients with history of hypertension, diabetes, and some systemic diseases. The signs and the symptoms are insidious with slight proptosis, projections without root, and we have to differentiate with the chronic conjunctivitis. And PSA is gold standard for diagnosis and treatment of this disease. The main treatment of this disease is embolization with coil or glue. This is the end of my presentation. Thank you so much for listening.
Okay, thank you very much, Dr. Zun, for your presentation. So topic is quite interesting. Before about more than, I think about 12 years ago, I have one doctor. He's do thesis. I am the superior for his thesis in the cardiovascular fistula. This is clinic at my hospital, and he also treatment by using coil for blockage of the fistula. And so results very good and very encouraged for the patient when they have the cardiac fistula going to my hospital for treatment. So any question or comment for the patient? Yes, Dr. Han.
A very interesting presentation, and you give many interesting information about the symptom and the diagnosis and treatment. 1 month ago, I had a patient, female, about 60 years old, and she came to exam for a recurrent of conjunctivitis, and with many time treatment with antibiotic and anti-inflammatory, but rigorous. And when I examine the female, this patient, that two sides I have to think about the carotid artery and cavernous fistula. That's dilation of conjunctivitis venous like a jellyfish. See, that's not very abnormal. Very dilation, and then exophthalmy. And then I sent the patient to do the DSA. DSA very important because not just diagnosis, but to give as a doctor to treat the patient. And then the DSA is confirm the diagnosis of fistula. Then I sent the patient to my hospital to intervention. I see the patient with Dr. Kwon also, Dr. Kwon. Very interesting case. So if you have a patient with a recurrent conjunctivitis with many treatment and sees exophthalmy and dilation of the venous conjunctivitis, and to think about the fistula. Thank you.
Okay. Yes, please, Dr.
Yeah, thank you for your presentation. It reminded me of something about my thesis. At that time, I was doing the thesis on a master degree about CCF. That's a long time ago, 2007, with Professor Hearn. At that time, we had some classification quite different with your classification you mentioned here. We call that CCF, direct and indirect, not DF, like your name. And CCF, we are direct, very popular, easy to explore. In the case of some patient with head trauma, protosis, bruise in your head, in